By the way, dear students, our lecture today is the fourth in a row in the discipline of traumatology, and orthopedics is devoted to a rather urgent disease that is treated not only by orthopedic traumatologists, but in most cases these are district therapists, neurologists, and this disease is called osteochondrosis of the spine. So what is osteochondrosis? Osteochondrosis comes from the Greek words osteon, that is, bone, and chondros, cartilage. That is, this is a dystrophic lesion of the articular cartilage, the underlying bone tissue, and at the heart of this disease is the lesion of the intervertebral discs. This lesion is accompanied by their progressive deformation, a decrease in their height, stratification, and, as a consequence, the appearance of all our clinical manifestations, symptoms, problems in patients, which we will analyze further in the course of this lecture. Theology. Osteochondrosis itself is a polyethological disease, which currently has dozens of different proven causes. It is believed that the development of degenerative dystrophic process in vertebral discs is promoted by unfavorable conditions of static loads on the spine. Moreover, both the unfavorable conditions that nature has laid down for us in the form of upright walking, and the peculiarities of our life, as well as a great predisposition has heredity, various variants of damage, overload of the spine structures, well, in particular, a large body weight. Well, here's an example sitting in front of you. That is, I have problems with my spine with a large body weight. These are various types of work related to carrying heavy loads. Variants of spinal deformities, ranging from minor, which can also lead to osteochondrosis, and ending with impressive and serious deformities, such as scoliosis, such as excessive kyphosis in the spine. Variants of circulatory disorders, in particular segmental circulation in the disc, various vasculitis, and other diseases can also lead to degenerative processes in the spine. These groups of causes lead to the so-called idiopathic osteochondrosis. At the same time, there is secondary osteochondrosis, and there are clear reasons for this. These are various injuries from minor to serious in the form of fractures. Yes, that is, spinal injuries that lead to the development of secondary osteochondrosis of the spine. One more time. Osteochondrosis of the spine is a dystrophic lesion of its elements, in which the process begins in the pulpous nucleus of the intervertebral disc, then gradually passes to the fibrous ring of the disc, spreading further to the bodies of adjacent vertebrae, to the intervertebral joints, to the ligamentous apparatus. Osteochondrosis of the spine is the most common chronic human disease. According to the number of days of temporary incapacity for work in our country, this pathology consistently ranks second after acute respiratory diseases, but also influenza, which brings significant economic damage. Therefore, the problem of osteochondrosis itself is not only a clinical problem, but also an important social problem in our country. So, let's remember a little bit about the anatomy and physiology of the spine. Moreover, we will approach the moment of the spine itself a little differently from how you viewed it on the anatomy cycle. So, the vertebral column in our understanding, in order to understand the pathogenesis of osteochondrosis, should be divided into so-called vertebral motor segments, which are a chain of interconnected vertebral motor segments. This is our spine. The vertebral motor segment, if you really imagine it, is such a virtual anatomical complex consisting of one intervertebral disc and two adjacent semivertebrae. That is, a disc located between the two halves of the vertebrae, respectively, with a ligamentous apparatus, a muscular apparatus, a nervous apparatus. Accordingly, if you imagine this, then you can consider the everyday logical situation that is happening here. Vertebral disc. What is it? The mobility of our spine of the spine, its elasticity. Elasticity is largely provided by this very intervertebral disc. The disc is cartilaginous. It consists of two dense plates of gyolin, tightly adjacent to the closure plates of the bodies of two adjacent vertebrae. That is, above and below the underlying vertebra. Between these two geolin plates there is a gel-shaped pulpous nucleus and a fibrous ring is located around it. That is, in essence, the intervertebral disc very much resembles a lens in appearance. The pulpous nucleus is a gelatinous mass consisting of cartilage cells located between intertwined collagen fibers. These fibers form a kind of capsule and give the core elasticity. Due to the elasticity of the pulpous nucleus, we form all our shock-absorbing properties of the spine. The diameter of the pulpous nucleus ranges from 1 to, well, let's say, in the cervical region somewhere up to 2.5 centimeters lumbar. There is a cavity in the center of the pulpous nucleus, and the volume of this cavity is also different. In the cervical region, this is on average 0.3, 0.5 milliliters, and in the lumbar region it is 1.5 milliliters. There are even such interesting research methods as discography. Well, in most cases, the method is old and gone, probably into history, because nowadays there are a number of minimally invasive, not so dangerous and complex technical implementation methods, but as such, the contrast radiographic method has taken place and is taking place. There is no need to forget about it. That is, in this very cavity which has a certain volume, you can get a needle, you can introduce a water-soluble contrast there. As a result, after taking the pictures, we will get what is called a discography, that is, an X-ray contrast examination of the intervertebral discs. The fibrous ring is located around the pulpous nucleus. Dense, connective woven bundles represent just the same fibrous ring. Moreover, in terms of its density and strength, the fibrous ring itself is not uniform everywhere. The posterior sections of the fibrous ring are about 2 times less dense, 2 times less durable than the lateral anterior sections, and this causes the vulnerability of these parts of the fibrous ring in the process of our pathological process of osteochondrosis. It is in this direction that the destruction of the fibrous ring and the bulging of the pulpous nucleus will mainly occur. Innervation of the vertebral motor segment. The innervation of the disc, capsules, joints, ligaments, vessels, membranes of the spinal cord is carried out by branches of the nerve. This is the sinovertebral nerve, sometimes it is called the recurrent nerve of the fluke. Now I will explain why this is so. In this colorful diagram, a sinovertebral nerve is drawn, which departs from each spinal nerve. It departs slightly distally from the intervertebral hamle, and then returns directly through the intervertebral opening and innervates what was said at the last wedding and, accordingly, directly in the fibrous ring and capsule of the intervertebral joint and performs sympathetic vascular nervation. As I said, the nerve is mixed. It includes both sensitive fibers and cute, sympathetic fibers. Nerve receptors are present only in the outer parts of the fibrous ring. Still, you need to understand that the fibrous ring is a cartilaginous formation and, as you remember, you have been told more than once since the histology cycle, cartilage is mostly devoid of both nerves and vessels. Thicker than cartilage, but the peripheral parts of the fibrous ring are innervated and quite sensitive in this case, that is, sensitive nervation. And damage to these areas, it causes pain impulses. Nutrition, that is, the blood supply to the intervertebral disc in childhood, somewhere under the age of 20, the intervertebral discs are combined. They feed due to the arterial vessels of the vertebral body. But after the age of 20, after a person grows up, cartilage tissue as such loses its own vascular bed and an insignificant, small volume of blood supply remains only on the periphery of the fibrous ring. Most of the fibrous ring, the pulpous nucleus, are nourished only by diffusion through the walls of the geolin plate. Here lies the whole foundation of our pathogenesis, that is, the moment of dystrophic disorders that occur with age. Pathogenesis of osteochondrosis of the spine. Intervertebral discs, as I have already said, are essentially cartilage tissue that changes its feeding zone with age. That is, there is a gradual physiological aging, as in any other tissue of our body, but in this case, aging is also caused by a violation, say, a change in the nature of vascular nutrition. In the late nucleus, with age, an imbalance occurs between the processes of biosynthesis and the breakdown of glucosamine. That is, this leads to a decrease in the elasticity of the intervertebral disc itself. The bullet core of the disc gradually decreases in volume, it breaks up into separate fragments. The fibrous ring also loses elasticity, softens, and thins. All this leads to the fact that in the subsequent, for example, X-ray or magnetic resonance examination, we will suddenly detect a decrease in the height of the intervertebral disc. Yes, in this case, we can say that the disc is thinning. At the same time, the ligamentous apparatus, laid down by nature, has the same length. Therefore, the vertebral motor segment in this case is already becoming ready for excessive mobility. Cracks begin to appear in the fibrous ring during dystrophic disorders. Cracks spread in all directions, but in the future they can form quite serious slit-like solutions between the gyolin plate and the fibrous ring itself. Sometimes, between the spongy bone and the vertebral body and the gyolin plate, there is also a detachment of this very gyolin plate. As we have already said, the fibrous ring is less durable in the posterior sections. Therefore, it is the posterior sections that are more susceptible to the formation of these cracks and crevices. Not all discs undergo dystrophic changes. Most often, the clinical manifestations of osteochondrosis are caused in the vast majority of cases only in a few of its departments. These are the lower cervical region and the lower lumbar region. And there are clear and evil, say, legitimate justifications for this. It is in the lower cervical, lower lumbar sections that these departments are subjected to the greatest local overload in humans during bends, during turns, while working with weights, while working in an uncomfortable position. That is why it is in these departments that these very cracks most often begin to appear. These are the very resolutions of the appearance of cracks in the intervertebral discs, more precisely in the spinal discs, namely in the fibrous ring. Pay attention to this scheme, that is, physical work associated with lifting gravity by a person. In the hands of a man lifts a barbell weighing 90 kilograms for an adult man, in fact, his own quite reasonable weight. Yes? We use the lever method, recalculate this case. This is banal physics. As a result, we can see that a force commensurate with a mass of 672 kilograms acts on the intervertebral disc L5 with 1. Quite a serious weight for such a small formation as an intervertebral disc. Under the influence of vocal overload of the vertebral motor segment against the background of dystrophy occurring in the intervertebral discs, 3 pathomorphological, and, accordingly, if we consider, then the pathogenetic situations listed above may occur. The first is a rupture of the fibrous ring of the intervertebral disc. The so-called simple disc break. This is usually the beginning of the disease itself, osteochondrosis of the spine. A more severe pathomorphological situation is the protrusion of the intervertebral column, that is, the protrusion of the pulpous nucleus through the torn fibrous ring. The so-called intervertebral disc protrusion. Here, pay attention, the diagram is drawn on the right, and here you can see this situation from the bottom of the second. And the third pathomorphological situation is the most severe. This is the loss of the intervertebral disc. That is, the pulpous nucleus falls out through the torn fibrous ring, and since we have already said that it is the posterior and posterior lateral sections of the fibrous ring that are most often destroyed, the pulpous nucleus falls out in the form of a prolapse in the direction of the spinal cord. Therein lies the danger of this situation. So, let's talk about the first pathomorphological pathogenetic situation, about a simple rupture of the disc, that is, the rupture of the fibrous ring of the intervertebral disc. Moderate local overload of the vertebral motor segment leads to the appearance of additional cracks, small ruptures mainly in the posterior and peripheral parts of the fibrous ring. Well, here is schematically displayed that zone of the fibrous ring, yes, in the diagram on the bottom right, where breaks and appearances occur. Ruptures of the fibrous ring are not accompanied by protrusion into the spinal canal, that is, these are so-called simple ruptures. Therefore, it is often quite difficult to see them, not even on tomograms. Whether it is magnetic resonance imaging, this matter is unnoticeable. Pay attention to the morphological macro-preparation of the human intervertebral disc, the seized, let's say, cadaveric material, where ruptures are visible, namely cracks in the fibrous ring. After a simple rupture of the disc, instability of the vertebral motor segment develops. With all the desire, the height of the disc in this case has already been reduced, the length of the ligamentous apparatus of the intervertebral has essentially been preserved, and we see such a phenomenon as instability. Instability of the intervertebral articulation, that is, excessive mobility above the underlying vertebra in relation to the underlying vertebra. When performing conventional spondylograms, that is, an X-ray of the spine, especially with functional tests, when the patient is asked to bend, straighten up and take pictures in different positions, it can be noted that there is a slightly small lists, that is, an offset above the underlying vertebra relative to the underlying one. The rupture of the intervertebral disc causes irritation of the end of the strongly vertebral nerve, which innervates the fibrous ring itself. This leads to a reflex contraction of the intervertebral muscles. That is, in essence, there is a functionally articular block. The body tries to get rid of excessive mobility in the intervertebral joint due to the constant tension of the intervertebral muscles. This leads to chthonic constant tension, and all this is accompanied, of course, by painful sensations. In addition to local, non-local pain sensations, the development of neuromuscular and vascular reactions is possible. Often, muscle nerves and vessels pass through the ears of those very muscles that, as a result of excessive mobility of the vertebral motor segment of the muscle, are tonally contracted. As a consequence, one can imagine that there is a strangulation effect, that is, compression of these very nervous and vascular formations. And this leads to the formation of so-called reflex syndromes of osteochondrosis of the spine. We will talk about them a little later when we analyze the clinic of diseases. Synogenesis, that is, what happens next and whether you and I will have some kind of recovery. So, the synogenesis of simple ruptures of the intervertebral disc. Ruptures of the outer sections of the fibrous ring are partially replaced after some time by a valuable tissue scar. The boundary at the beginning is represented by a loose, fragile garnish tissue and turns only after 1, 2, 3 months under favorable conditions, yes, that is, when immobilizing, removing loads in this case from this vertebral motor segment of thin fibrous and then roughly fibrous and cartilaginous tissue. Often, there are gaps in the central parts of the disc which do not form, and this leads to the fact that the disease itself is chronic osteochondrosis. Phenomena such as simple breaks can be repeated, and in some cases the picture may be aggravated by the second form and the third form, which we will talk about later. Thus, partial fibratization of the intervertebral disc occurs in the process of recovery. Irritation of the end of the sinus metibral nerve in the outer parts of the fibrous ring stops. During the first half of this period, 1, 2, 3 months, which we discussed, that is, for 4-6 weeks, there is a rather high risk of relapse of the disease due to a possible re-rupture of the intervertebral disc, even with a slight local overload of the vertebral motor segment. Therefore, in the treatment of exacerbation of osteochondrosis, it is necessary to specify the mode, the motor mode in the spine of the patient, to remove loads. That is why patients are often transferred to the mode of disability risk, if their work is not associated with lifting weights, with physical exertion. And that's why we discussed the situation with you that osteochondrosis is a socially significant problem that takes a person out of a state of working capacity for a long time. The second pathomorphological pathogenetic situation is protrusion, and a person is called a protrusion of the intervertebral disc. It occurs already with a pronounced vocal overload of the vertebral motor segment. Through the resulting large rupture of the fibrous ring towards the spinal canal, well, that is, in the posterior direction, in the posterior lateral direction, in the place where the most fragile fibrous ring, there is a displacement of fragments of the nucleus pulposus and, as a consequence, this leads to protrusion, that is, to the protrusion of the disc. The posterior sections of the fibrous ring protrude, but do not rupture. That is, they keep a fragment of the pulpous nucleus from falling out into the spinal canal. This can be confirmed here. You see, contrast radiography, that is, discography. And in this case, this situation is called protrusion. And this is how it differs from the third situation, which is called. There are two types of protrusions. The bulge is elastic. That is, yes, elastic protrusion is a slight displacement of all fragments of the pulpous nucleus. And in this case, such a protrusion can migrate back into the disc cavity and occur in the board directly of this very one. The serious situation is pathokinetic. This is a sequestered bulge. That is, sequestered protrusion is the displacement and infringement in the posterior parts of the disc of a large fragment of the pulpous nucleus and sometimes also a detached part of the fibrous ring. Sequestered protrusion occurs in cases where there is a slit-like resolution between the geolin plate and the fibrous ring, as well as between the spongy bone of the vertebral body and the geolin plate. Here, pay attention to how schematically it all looks. Yes, there is a picture on the left with a schematic protrusion, both in a three-dimensional image and simply schematic. And on the right we see with you a variant of a computed tomogram of the spine, where we see a protrusion. At the bottom in the middle we see a magnetic resonance imaging tomograph, which also presents options for protrusions. Third, according to the morphological situation, it has already been discussed. This is a more difficult situation. This is a prolapse of the intervertebral disc or prolapse. That is, with severe local overload of the vertebral motor segment, often against the background of previously simple ruptures or protrusion of the intervertebral disc, complete rupture of the peripheral parts of the fibrous ring, sometimes even the posterior longitudinal ligament, occurs. As a result of this rupture, a pulpous nucleus falls into the spinal canal, often together with a fragment of the fibrous ring, and in some cases even with a part of the galena plate of the vertebral body. A partial or complete loss of the disc is formed, the so-called prolapse of the disc. Well, here we also have an MRI tomogram of such a phenomenon and a schematic image of such a hernia. We will continue to say that often the phenomenon of prolapse and protrusion has a common name. It is a spinal hernia. Herniated intervertebral disc. Depending on the location of the protrusion or prolapse along the diameter of the spinal canal, that is, in the direction in which the protrusion occurs, the following directions are distinguished. These are the median rights in the village of protrusion, paramedian, posterior lateral and foraminal. Foraminal is a protrusion into the area of the intervertebral foramen. In the second and third genetic situations, the protrusion and prolapse of the intervertebral disc may occur not just irritation syndromes, which we have described as reflex syndromes, but also syndromes with the pressure of nerve structures, that is, the spinal cord and spinal roots. And such syndromes are called compression syndromes of osteochondrosis of the spine. We will also talk about them later when we disassemble the clinic. The protrusion and prolapse of the intervertebral disc in the literature is often referred to as a hernia in one word. That's what we talked about, right? That is, herniated intervertebral disc, or then they are called spinal hernias. But it is necessary to specify the type of hernia, since the clinical manifestations and prolapses of protrusion, as well as the treatment tactics for each variant of them are different. They also differ from the direction of the direct bulge. Stenogenesis, prolapse and bulge. In principle, the prolapse and protrusion of a disc fragment, that is, after some time under the influence of our autoimmune processes, are reduced in volume. Sometimes, if they are insignificant, they dissolve completely, sometimes they are replaced by a coarse, woven formation, but with all the desire, this fragment of tissue is considered dead in our body and our protective, that is, the immune system will try to destroy it. Decreases after some time. Reflex muscle spasm, as well as after a simple rupture of the disc, instability of the vertebral motor segment occurs, which in this case lasts much longer than with a simple rupture and can take whole months. The long-term existence of instability of the vertebral motor segment, which leads to minor displacements of the overlying vertebrae in relation to the gland, constantly contributes to the scar adhesive process in the spinal canal, dystrophic changes in the intervertebral joints and in the ligaments of the spine when moving. This often leads to the development of spondyloarthrosis, yes, various ligamentoses, as well as constant chronic irritation of the attachment zone of the tendons can lead to the formation of bone cartilage splints on the vertebral bodies, that is, to the formation of so-called spicules. Here, on this diagram, the whole is combined into one single scheme, that is, the dynamics of pathomorphological and pathogenetic situations in osteochondrosis, what we have been talking about for the last literally 10 slides. Clinical syndromes of osteochondrosis of the spine. As mentioned above, we distinguish reflex syndromes. Caused by reflex spasm of muscles, vessels of limbs, trunk. There are muscular conical, neurodystrophic, neurovascular syndromes. And they distinguish compression syndromes in a more severe pathogenetic situation, when we have a protrusion with you, when that is, in the direction of the spinal cord roots or spinal cord, or even worse, when we have prolapse. Compression syndromes are caused by the pressure of neurovascular formations on the spinal canal for the roots of the spinal cord or vertebral arteries. So, the common syndrome for all parts of the spine is probably at the initial stage. The so-called vertebral syndrome. This is a feeling of pain, tension of the muscles of the trunk, limbs, and restriction of movements, curvature of the spine axis, and in some cases, on the contrary, even straightening of natural physiological bends. Subsequently, the syndrome of instability of the vertebral motor segment is formed. We talked about why this is happening. Instability syndrome is characterized by an increase in pain syndrome after the patient moves from a horizontal to a vertical position. And also with rotational movements of the trunk. That is, when a person moved from a supine to a standing position, pain appears. When a person does something, you have to turn around, there is pain. The pain is getting worse. Reducing pain in a horizontal position, that is, when a person lies down to rest, the so-called pain syndrome gradually passes. Inflector syndromes of cervical osteochondrosis or so-called osteochondrosis of the cervical spine. Cervicalgia. Acute or chronic neck pain. The most likely reason is the instability of the disc C30, C4, C4, C5, C5, C6, C6, C7. That is, almost the entire lower cervical region, which we ourselves said, the instability of these discs leads to cervicology. They are more aching in nature, sometimes radiate to the back of the head, shoulder pads, upper interscapular area. And many of you, probably, even now already pay attention to yourself that at yourself, even at your age, sometimes this is already present. Pain appears or increases with movement in the neck, as well as with prolonged monotonous head position. Well, pay attention to the scheme and to the localization points of these very pains. The next syndrome characteristic of cervical osteochondrosis is the syndrome of the lower oblique muscle of the head. The most likely cause is the instability of the C34 and C4, C5 segments. With tonic tension, the muscle presses the vertebral artery to the capsule of the joint C1, C2. In this case, it means touching the muscles of the head. In addition, the large occipital nerve is irritated. Movement is blocked in the joint C1, C2, that is, in the one that is most mobile with us during rotational movements in the cervical spine. Clinic. Pain in the cervical occipital region of a permanent nature, which increases when trying to rotate the head in a healthy direction. Another interesting reflex syndrome of cervical osteochondrosis. Anterior stair muscle syndrome. The most probable cause and stability of C6, C7 and C5, C6, that is, the lower cervical segments completely, occurs with reflex tension of the muscle of this most anterior staircase from the pressure in the corner between the anterior muscular muscle and the first rib of the lower portion of the trunk of the brachial plexus, and in front in the gap between the first rib and the clavicle of the subclavian vein. The clinic is very peculiar, but very common in cervical osteochondrosis, pain in the upper limb, hypergesia, and motor disorders in the area of innervation of the ulnar nerve. That is, if you ask a patient a question, by the way, even ask yourself this question. And sometimes you wake up and don't you feel numbness in the fourth or fifth fingers of your hand? A lot of people will answer positively that yes, they have such a clinic quite often. Pain with anterior muscular syndrome also haunts the upper extremities of a person and increases when turning or tilting the head in the opposite direction, that is, in the opposite direction from the aching upper limb. Brachiopathic periarthrosis syndrome. Sometimes they say shoulder periarthritis, and often many neurologists even isolated this syndrome as a separate disease. Although in fact all the slaughter is a syndrome of cervical osteochondrosis. The most likely reason is the instability of the disc C5, C6 and C4, C5. The adductor muscles of the adductor shoulder are reflexively spasmed, that is, it is the large pectoral and large round muscles. Then there are dystrophic changes in the periarticular tissues of the shoulder joint, because through these rather massive muscles there are vessels that feed the capsule of the shoulder joint. The clinic is pain in the shoulder joint, movement restrictions. Yes, restrictions on the amount of movement in the shoulder joint. 3 palpals are determined by painful spasmodic nodes in the thickness of these very large muscles, especially the large pectoral muscle. Here, pay attention, local areas are drawn here, during palpation of which the so-called trigger zones will be marked, that is, very painful zones. Anterior chest wall syndrome or pseudocardial syndrome, oddly enough, is the most familiar to all students. Either they remember it strongly, or you are very good at teaching internal diseases when you undergo differential diagnosis of angina pectoris. So, the most likely reason is the instability of the disc C4, C5 or C5, C6, clinic of chest muscle pain on the left. Well, in this case, as you understand, if we have pain on the right, then there will be no pseudocardial syndrome. With recoil in the interscapular region and in the left upper limb. When palpating the mouse, painful nodes are detected. The pain syndrome differs from the truth on the map as follows. This is a wider pain zone, significant, prolonged pain over time. Then you realize that with angina, such prolonged pain is not characteristic. The absence of hemodynamic disorders and, probably, the most noticeable thing, what complete students are is the absence of changes in electrocardiography. Well, accordingly, the ineffectiveness of taking nitrates, which usually relieves the pain component in angina. That is, the banal old ancient nitroglycerine tested there. It will be ineffective with pseudocardial syndrome. Another interesting syndrome is the vertebral artery syndrome. In this case, it already belongs to the group, probably, vascular syndromes. The most likely reason is the instability of the CE3, CE4 and CE4, CE5 discs. That is, if we take the most common pathology zone of the lower cervical region, so this is the upper part of this very lower cervical region. There is a transformation of bone tick-like sprawl, that is, this is already a fairly advanced stage of osteochondrosis, and the proliferation of these spicules, the proliferation of bone esophaguses and sprawls squeeze the vertebral artery, which, if you remember, goes into the thickness through the transverse processes of the cervical vertebrae through a special opening of the vertebral artery. Clinic. As a result of compression of the vertebral artery, the discharge of blood into the basilar and, accordingly, the posterior parts of the Vlisium circle is disrupted. There is a redistribution of blood flows within the Vlisium circle, and as a consequence this leads to ischemia, that is, some kind of violation in the nutrition of the brain. All this is manifested by headaches and migraine-type pains. The pain spreads from the cervical occipital region most often to the temple and to the forehead. And headaches in this case have their own characteristic name, that is, pains by the type of removing the helmet. In addition, cochlear-vestibular disorders may appear, that is, they may manifest as tinnitus, dizziness. Their intensity may vary depending on the position of the head. That is, here is a direct example. I had a classmate who suffered from this pathology quite often. Recently, for some reason, it has passed. That is, most likely, this excessive mobility in these segments of the spine has been stabilized, but this case was manifested in his case by the fact that he could not drive. Especially on rough roads, over rough terrain, he began to feel dizzy, nausea began. I will help in this situation, the situation when he started riding in a head holder, in a soft head holder, the chances of movement decreased. That is, this bold anchor in the vertebral motor segment has decreased, and as such the symptoms have passed. Well, after a full-fledged treatment of cervical osteochondrosis, he got rid of such manifestations, given that the disease is chronic, so he lives in anticipation of an exacerbation again. Compression syndromes of cervical osteochondrosis, as we have already said, are a neglected situation when prolapse occurs, or with a sufficiently powerful protrusion, namely protrusion, which we have a pinched protrusion. Spinal cord root compression syndromes. The spine of the spinal cord nerve is a part of the nerve located in the epidural space from the dura mater to the spinal gamma, that is, just passing through the hole, through the very parameter that we talked about. There is irritation, that is, irritation of the root, or with pressure, that is, compression of the root. As an outcome, there may be atrophy in this case of the root and a violation of the conduction of impulses along the nerve that is in this. The compression of the spine of the central nervous system is shown here in this diagram. I will not discuss compression syndromes with you in detail now. With all the desire, after all, this is probably not orthopedics, but pure neurology. Therefore, independently viewing these weddings, please pay attention to where we have a violation of the sensitive sphere, what motor disorders can, namely, let's say, the strength of which muscles, yes, can decrease, and what reflexes we have in this case when evaluating, yes, reflexes from this particular area. We have problems with this performance of these reflexes. Here we have the root of the C6. The spine is C7. In this case, here it is presented here. You see, you already have clear differences. Yes, if here we have excellent on the 6th root, that is, the zone of sensitivity disturbance was in another place, then here we are about to feel violations along the course of the median nerve. There is also a violation of motor function. Yes, the muscles flexing the wrists. To a greater extent, they are represented precisely in the portion of the radial nerve. In this case, the strength of the muscles flexing the wrists is reduced. Depression of the root of the C8, that is, it is C7T1 segment is represented in this case here, and here we already see that sensitivity is violated precisely in the projection of the ulnar nerve, that is, yes, here is a blue area of decrease, that is, a violation of sensitivity. In addition to all this can be accompanied not only by a decrease in sensitivity, but also by the occurrence of paresthesia, that is, incomprehensible sensations, sometimes a burning sensation, feelings of, say, needles, and so on. Plus, the motor function is impaired, you see, in the flexion of the fingers and the function of the interosseous muscles, which are responsible for the dilution of the fingers of the hand. Spinal cord compression syndrome, that is, not the roots, namely spinal cord compression. Hyperpogenic cervical myopathy is probably one of the most terrible manifestations what cervical osteochondrosis can lead to. The reason is compression of the spinal cord due to protrusion or partial fall of the intervertebral disc, as well as in the presence of posterior marginal bone growths. This may also be the bodies of the cervical vertebrae. The typical occurrence of the syndrome in individuals already with a congenital narrow spinal canal at the cervical level. The first and clinical manifestation is most often a slowly progressive spastic cut in the lower extremities. Then weakness and atrophy of the muscles of the upper extremities are already increasing. Sensitivity disorders are not typical. Usually there are minor delays or imperative urge to urinate, that is, we already have the function of internal organs begins to suffer. The clinic of vertebral cervical myopathy in many ways resembles amyotrophic lateral sclerosis or surgery or. That is, as a disease for differentiation, it is always necessary to take this into account and remember that such a common disease as osteochondrosis can lead to such serious neurological disorders. To clarify the nature of the lesion, studies are used. That is, in the past, the study of liquor was widely used and myography was also given, when contrast was injected directly into the spinal space. Yes, that is, when performing a puncture of the cerebrospinal fluid, a water-soluble contrast was injected there. It was performed with a pose, that is, a snapshot of the spine. Honestly, not the most pleasant. Firstly, invasive, and secondly, diagnostic manipulations that are difficult for patients to tolerate. Now everything has become much easier when we have such precise, let's say, instrumental techniques as computed tomography and magnetic resonance imaging. That is, it allows a fairly accurate diagnosis to be carried out painlessly for the patient. An adapter for lumbar osteochondrosis. Reflex syndromes. That is, as you understand, reflex syndromes are much more common, because this is the initial level of symptoms, and compression syndromes are already an advanced severe form of osteochondrosis. So, the reflex syndrome of lumbar osteochondrosis is the lumbalgia syndrome. The reason is a simple rupture of the fibrous ring or instability of the discs L3 or 4, for 5 and 5 with 1, that is, the lower lumbar region of the lumbar spine. Clinic of pain in the lumbosacral region of a sharp or aching nature which increases with movement. There is a tension of the muscles of the trunk, a sharp restriction of leaning forward and to the sides. Often, pain occurs the next day after an overload of the lumbar spine. This is called the phenomenon of the second day. That is, we are digging potatoes on Saturday, Sunday. On Sunday evening we have fun, drink, walk, celebrate the day of the summer resident, and on Monday we can't bend, straighten up from the strongest pain in the lower back. All this is caused by edema of fragments of the pulpous nucleus of the disc, yes, shifted into the cracks of the fibrous ring and as a consequence of reflex impulses from this fibrous ring, indicating that pain. The pain appeared. It hurts. Lumbago syndrome is an acute pain in the lower back. The reason for the movement of a small fragment of the pulpous nucleus of the disc is L4, L5 and L5 with 1 and its infringement in the outer parts of the fibrous ring. That is, in this case, the clinic is an acute pain in the lumbar region, most often when trying to lift a weight, that is, when a person is in a bent position, lifts a weight, and sometimes patients call this type of pain a lumbago. The torso functions in a half-bent position. The patient is, as it were, fixed in a bent position and he cannot straighten up. He's just really hurting. In this position, he walks, moves, and some functions even try to perform self-service. Another rare reflex syndrome, but at the same time, which should not be forgotten. This is a syndrome of the piriformis muscle. The reason is a simple rupture, instability of the disc L5 with 1. A reflexively tense piriformis muscle irritates the sciatic nerve at the point of its exit from the pelvis. Clinic of pain in the depth of the buttock, more radiating to the lower limb and reaching up to the foot. Yes, according to anesthesia in the lower extremity, which increases when walking and when bringing the hip inside beyond the middle line. According to anesthesia, they can manifest themselves in a feeling of needle pricks and in burning feelings. That is, many people describe the situation in such a way that they are directly burned along the back of the thigh from the buttock. Compression syndrome of lumbar osteochondrosis. The syndrome in the valley of the root 4. Yes, the reason for the bulging or falling out of the disc is either 3 or 4, as well as with the cervical department, again, taking into account the fact that, after all, it is mostly pure neurology. Please see for yourself those areas, yes, where we cannot violate the sensitivity to mark the areas of weakness of the muscular apparatus. Well, in this case, it's weakly quadriceps, and, accordingly, a decrease in the knee reflex. All this is characteristic of compression syndrome precisely for compression of the root of L4. The syndrome with the pressure of the root L5. A little differently, the sensitivity disorder is already localized with you and me. We answer the weakness of the back flexion of the big toe gives a violation of motor function. With compression, either irritation of the root and other pain sensations may have absolutely different localization. Right here in red we have marked the zone that will be. That is, a person will make complaints in these areas of the lower limb. Syndrome with root pressure with 1. It is characterized by a violation of sensitivity already along the back of the lower leg with a transition to the outer part of the foot, a decrease in the flight reflex and weakness of the sole flexion of the foot. When compressing the irritation of the root with 1, pain can also have different localization. Here, pay attention, up to the point where our heel hurts. In this case, he may have an imitation of a heel spur. Yes, the back surface of the shin hurts with an imitation of Achilles bursitis. This is in terms of differential diagnosis. The syndrome of acute cut of the roots of the ponytail, the tops of lumbar osteochondrosis are the most dangerous, the most formidable, say, manifestation. The reason is the median prolapse into the spinal canal of the contents of discs or 2 or 3, or 3 or 4, or 4 or 5 with 1. That is, the entire lower lumbar region. The clinic of pain in the area of dermatomes with 1 or 5 or 4 or 3. Gross sensory disturbances in the perineum, pelvic disorders, yes, for working with organs of urine excretion, yes, violations of defecation. Depending on the level of disc prolapse, cuts of the feet, thigh muscles, and the absence of archives of knee reflexes may be attached. The method of clinical examination of the patient. Everything definitely begins, probably, with a survey of the patient, yes, with a study of his complaints, and even more interesting with the history of the appearance of these complaints, that is, the study of the anamnese of the disease. The main attention should be paid to the characteristics of the dynamics of the pain syndrome from the moment of its appearance, that is, from the moment of exacerbation of the disease. In most cases, patients can quite clearly outline the area of pain. It corresponds most often to dermatomas, myotomas, and sclerotomas. When you meet such terms in neurology, I hope, you remember what it is. A dermatologist is a skin area in which the sensitive nerve endings of the posterior root, connected to a segment of the spinal cord with a certain segment, spread. Myotome is a group of muscles formed by the same segment through the anterior spine. And the scleroatom is a zone of innervation by the root of ligaments, fascia, tendons, periosteum. Here, pay attention, that is, the scheme and the radiation of pain by dermatomes allows us to assume that the compression of which spinal cord root has already occurred. And in this case, such, say, professional skills are possessed by good neurologists. Well, it's probably their bread. More giving on the dermatome has a sharp shooting character. The technique of showing or drawing the spread of pain is used when patients are asked to show where exactly they have pain, how it spreads, from where to where. Pain in the area of myotoma and sclerotoma have a nagging, burning character. This is a deep character. They occur when the spinal nerve root and sinovertebral nerve receptors are irritated. They are caused most often by reflex muscle spasm. Here the pains are localized in the joints and ligaments. They are called myosclerotomic fights. Here pay attention to these schemes. Here, accordingly, exactly those segments, those roots that we are involved in, that is, irritated, are presented. Objective examination, that is, physical examination of the patient. An examination is carried out, an assessment of the configuration of the spine at rest and during the movement of the trunk. To identify, remember, I told you that sometimes there is a smoothing of natural bends. So we can detect the smoothing of the ordosis, right? And vice versa, strengthening of the establishment of thoracic kyphosis or hypoordosis of the spine. Pain myofascial points are determined by palpation. These are areas of irritation of nerve receptors in the area of dystrophically altered muscles. Most often, in the thickness of the muscle, we can palpate dense balls, dense formations of those already fibratized muscles. In the case of cervical radicular syndromes, you can change the spooling test. That is, when loading on the head tilted on the shoulder, pain may occur in the area of nervation of the compressed root. The Bursey test, a test for compression and stretching of the cervical spine by the hands of a doctor. This can lead to increased pain when we perform compression, or to a decrease in pain when we stretch the cervical spine. In patients with root pressure at the lumbar level, a symptom of a cough push is detected, or such a rather inhumane thing as a Bell symptom syndrome. That is, the radiation of pain on the dermatome during coughing. That is, we press on the intervertebral area with our finger and ask the person to cough. He begins to have pains, yes, which are characteristic in this particular case. Here is the irritation of this root. Or when pressing the hand into the area of the intervertebral opening, the patient begins to leave and complain of pain. This is a symptom of a bell, a doorbell. As you understand, here it is an analogy, that is, with pressing the doorbell button. The symptom of muscle stretching is most well known to you. I think I'm not the first one to talk about it, Lasaga's symptom. The patient lying on his back raises his straight leg up. Normally, a healthy person can safely raise his leg to the level of 90 degrees. With radicular pain syndromes, the angle of ascent is significantly reduced due to painful tension of the posterior muscle group, yes, because of the pain that appears like this. Symptomatic, when the patient's head is bent to the chest, lying on his back, the root pains in the lower extremities begin to intensify. Instrumental research. We have already talked about spondyography more than once. That is, it is an axis radiography of the spine, most often performed in two projections. Sometimes we can talk about functional tests when spondyography, for example, in a lateral projection, is asked to be performed in a calm position, as well as when a person bends or unbends the spine. Pause it out. The following signs of osteochondrosis of the spine are revealed. Here, unfortunately, is the radiography. The X-ray, more precisely, is not the highest quality in terms of our disease. It is quite muddy, analog, but so far at the moment, most often we have to deal with such and such in our domestic healthcare. It is necessary to change, of course, to digital. So, a decrease in the height of the intervertebral disc. Here, pay attention to the picture. In the upper cervical region, the intervertebral discs are quite wide and extensive. We have said that most often the problem is in the lower cervical regions. Pay attention to the lower cervical region. What narrow intervertebral discs are here? This is the first manifestation that is easy to notice on an X-ray examination. The second manifestation is the expansion of the cornice and caudal areas of the bodies of adjacent vertebrae. That is, the lower part of the overlying vertebra, the upper part below the underlying vertebra. You can see how in the lower cervical region the pads themselves are much larger. That is, they expand due to the appearance of bone outgrowths, the same ones. Subchondral sclerosis, that is, in the area adjacent to the intervertebral disc, the section of the contact plate of our vertebra becomes very dense. It's sclerosing. By the way, if we consider this situation, sclerosis assumes that our bone tissue is being assimilated. It becomes less porous, fewer vessels pass through it. And if we extend the thought further in terms of pathogenesis, since fewer vessels fit exactly to the contact plate zone, it means less nutrition in this zone. Less nutrition means that the part of the cartilaginous intervertebral disc that is carried out due to diffusion will be fed less. Here's a vicious circle for us. Posterior, anterior marginal bone growths of the vertebral body. The so-called eucovertebral overgrowth. Here, in the lower cervical sections, they are very seriously even noticeable. Pathological mobility in the vertebral segment. Here it can be revealed when performing those very functional tests. When they ask to make a lateral projection in an even position of the body, they ask to bend forward, or to bend strongly. We suddenly notice minor moments or paths, that is, the displacement above the lying vertebra in relation to the lying below. Usually, for these purposes, they look at the back surface of the vertebral body and, accordingly, compare the lines above the lying vertebra below. Straightening of physiological lordosis, local kyphosis, a symptom. Well, in this case we have already talked about it. Myography with a water-soluble contrast agent. In the methods, I have already said before, it is very widely used. Now it is less and less used due to its rather difficult patient tolerance. Signs of deformation of the subarachnoidal space, characteristic of protrusion or prolapse of discs, cicatricial adhesive processes, and other pathological changes in the spinal canal are determined. At the moment, of course, magnetic resonance imaging allows you to see the same thing, but without causing unpleasant sensations. Discography. We talked about it at the beginning of our lecture. This is a direct examination of the intervertebral disc by introducing a contrast agent into the zone of the purposive nucleus. Allows you to visualize the pathological change of the disc, establish the relationship between it and the chronic manifestations of the disease. Causing pain typical for the patient during the introduction of contrast. The disc begins to increase in size, it begins to bulge. At the same time, you and I can clearly contrast the disc. I will not say that this is a frequent diagnostic procedure in itself. For us, for example, it is accompanied by the fact that it is very difficult to get a needle into the zone of the intervertebral disc. At the same time, if we have already had such a phenomenon, then often the diagnostic procedure can become therapeutic and diagnostic. In this zone, instead of contrast, after we confirm the correctness of our hit in the pictures, various substances can be injected. We will talk later about the cheminosis of the discs, yes, and this option involves therapeutic manipulation. Vertebral angiography. Yes, for example, the symptom is the one we talked about, vertebral artery syndrome. We can confirm the angiography of the vertebral artery. It is compression of the vertebral artery by bone speech growths. Here, pay attention here. Yes, you can see how they press on the vertebral artery. Ultrasound Dopplerography of the vessels of the neck, brain, USDG. This method is presented here. It allows you to already determine volumetric, say, data on the passage of blood through the vessels of the neck. In this case, we are interested in the vertebral artery. CT, computed tomography of the spine. The modern technique allows you to visualize pathological changes in the discs, in the vertebral bodies. In 30 to 50% of cases, there are changes in the spine. Yes, when performing this, say, diagnostic procedure, not even because of osteochondrosis. Yes, in parallel, most often the diagnosis also describes the presence of osteochondrosis, provided this, the patient has often not noticed any clinic before. Well, here is another of the options for computed tomography, so that you once again understand that computed tomography is not necessarily a three-dimensional picture, right? Most often, after all, this is a tomography. These are slices at certain levels. The same is the situation with magnetic resonance imaging. But in this case, if computed tomography still involves an X-ray technique that is unsafe for humans in terms of radiation and to a greater extent qualitatively shows us exactly the problems associated with an artificial apparatus, then magnetic resonance imaging to a greater extent allows us to see soft tissue structures, the same intervertebral disc, of course. It can be seen more qualitatively on magnetic resonance imaging. Well, provided that maybe she herself does not give the resolution as accurate as CT, but we clearly see both the problem associated with the disc and the problems associated with the spinal cord. Please note that we are here with you on these CT scans at the computer, that is, on these magnetic resonance tomograms, and observe. Well, here's another one of the MRI options. If the picture in the previous pictures was too bright, yes, related to the rights with the disc, then here we will find a clear protrusion even in several places. Pay attention. We turn with you to a rather interesting topic, the treatment of osteochondrosis. Conservative methods of treatment. That is, what a general practitioner does with us, what a district therapist, a neurologist, including an orthopedic traumatologist, does with us. So, conservative methods of treatment are the main treatments for the disease of manifestation, that is, osteochondrosis of the spine. They can be divided into 4 groups. These are medical methods. Well, here you can see the listed tools that are most often used. This is an anti-inflammatory, analgesic from the NSAID group. It is a means of stimulating reparations, improving nervous traffic. Most often, these are vitamins of therapy from group B. These are weak muscle relaxants. You know them too. These 3 groups of drugs form the very so-called triad, which are almost always unnecessarily prescribed for exacerbation of osteochondrosis. The second group of conservative methods of treatment is reflex techniques, physiotherapy, various aspects of acupuncture therapy, that is, I say reflexology. Perhaps laser therapy, taking into account the impact on biologically active acupuncture points. And the use of these irritating agents to this day has not lost its significance, and the use case is more here from the derivatives of capsicane, or that is, pepper. Yes, that is, it is banal in our own surgical plastry. With all the desire, they have changed very widely anyway. The third group of conservative techniques is vert neurological techniques. These include various biomechanical techniques, that is, traction with stretching. Starting from the fact that a person in terms of gymnastics, yes, certain, let's say, gymnastic techniques are defined. Plus, the banal visa on the crossbar has a fairly good therapeutic effect for lumbar osteochondrosis. Manual therapy, oddly enough, some are its supporters, some are opponents of manual therapy, but it allows us in most cases it is still a vertebroneurological method of treatment. This can also, in theory, include surgical manipulations. A little later we will talk about them in more detail. And local anesthetic techniques. Blockades. Drug blockades with the use of local anesthetics, which allow us, if we recall such a term as a vicious circle in pathophysiology, to break these vicious circles. That is, the introduction of a local aesthetics into the projection of a strongly vertebral nerve interrupts the flow of impulses along it. As a result, the return in the form of a command for constant muscle spasm is also interrupted. The conductivity in the thickness of this muscle along the nerves and vessels improves, nutrition is restored, and we break the vicious circle. With simple ruptures of the disc and instability of the vertebral active segment. Here, pay attention to what techniques it makes sense to apply here. So, but are harmed methods. Bed rest is banal, that is, we relieve the load on the spine. The use of external locking devices. If we take the cervical spine, then a soft head holder. We will sort it out in class. If we take the lumbar region, then corsets are semi-rigid, quite acceptable and widely used. We must not forget that these things exist. Books often don't say much about them, but as orthopedic products, this is quite an affordable thing now. Reflex methods of treatment. Irritating drugs on the relevant areas of the skin. Yes, I don't often recommend such techniques now, but you don't need to forget about them. Precise massage, a puncture. We have already discussed medical treatment with you. A triad consisting of a non-steroidal anti-inflammatory agent, vitamins, a complex preparation of B vitamins and weak myrrh-allowance. Sometimes ointment forms are added to this case and often they also have an irritating property. Here you see, it says bee venom, snake, well, that is quite acceptable. With the protrusion of the intercostal disc, orthopedic techniques are already being added here. Bed rest is definitely assigned. Sometimes the patient is even hospitalized. Attraction treatment, stretching is performed. That is, I have already told you about just the spring of the crossbar. Sometimes special attraction tables are used, yes, that is, such manual, say, devices. Manual therapy, external fixation device. We talked about them at the last wedding. Medication is also used, but in this case, in addition to oral administration, yes, there is also a protoral form of management of both non-steroidal anti-inflammatory drugs and vitamin relaxants. And sometimes the technique itself, in such a more severe situation as intervertebral disc protrusion, involves hospitalization of the patient, a parathyral route of administration of drugs, yes, followed by a gradual transition to oral administration of the entire course dose. We talked with you about the cocaine blockade, well, or lidocaine blockade in this case, yes, that is, as an effective method. Plus video treatment. With a partial attack of the intervertebral disc. VTA is an armored method, bed rest, and often strict bed rest is prescribed, blockades and medical treatment, too, which we have bed plus video treatment. Let's pay a couple of slides to drug therapy, that is, banal pharmacology. Here on this slide are the weak muscle relaxants most often used for the treatment of osteochondrosis, that is, the group of drugs that is prescribed either in oral form, or in principle there is a protoral form of management. Serdout and Midocil are most often used. Well, here you have the multiplicity of intake per day, the daily dose. Moreover, it is stipulated that both BTO and that drug should be used not just in a certain dose. Here today I am prescribing you, say, 2 tablets 3 times a day. Such a reception can be very poorly tolerated by patients, therefore, a gradual increase in the dose to the same therapeutic dose and a decrease in the daily dose is assumed. Therefore, in a conversation with a patient, you will need to describe exactly the quantitative intake, decomposing it into a course dose. It is usually 10 days. That is, on the course for 10 days, explain that today we drink half a pill 3 times a day, then we drink a pill 3 times a day, 1.5 pounds, then 2 and so on. The maximum daily doses here have been translated for these drugs. Well, it should also be said that Midocil has a less pronounced relaxing effect, but it is often much better tolerated by patients. If it works more rigidly, yes, it relaxes so that the patient often feels weakness, excessive weakness, but at the same time it works more effectively precisely to relax the muscles. A group of drugs, and there are a number of drugs. These are vitamins, complex preparations from group B vitamins. Well, again, here are the 3 most widely used now in the clinic. These are Mildema, both paratherally and orally, Combilipin, Neuromultivitis, the most widely distributed. A simple form of reception described in the instructions. The maximum should be said that the course dose of this drug, given that it is vitamin therapy, should not be the same 10 days. And a staff error when everyone is assigned at the same time. It is necessary to explain to the patient that vitamins therapy is the lot of at least 3 weeks. That is, it is 21 days, or even pain will need to drink these drugs. Let me not analyze the third part of the triad of nonsteroidal anti-inflammatory drugs in this lecture with you in detail. But the next lecture, which will be devoted to osteoarthritis, we will focus in detail on the selection of NSAIDs for various concomitant pathologies, yes, when selecting the dose of NSAIDs and, accordingly, it's, well, the name of the name. With the development of instability of the vertebral motor segment, much attention is paid to the immobilization of the affected spine. We talked about the cervical section with the use of chance collars, yes, and about the lumbar section with the use of corsets. Do not forget about it. Means that stimulate local myofixation, that is, acupuncture, physical therapy, physiotherapy. Previously, drugs that stimulate reparative processes were widely used. Most of these drugs are still present in, let's say, the pharmacopoeia list, but at the same time, many of them do not fully understand the effect of their effects and they are not always widely prescribed for this reason. For example, such drugs are Rumelan. To a greater extent it is a chondroprotector. The vitreous body of aloe, FITs, if you remember, are biogenic stimulants that contribute, well, to the stimulation of the formation of connective tissue. Here to understand to the end the effect of their work, that is, the principle of operation is not clear, but the effect of some is present, we must not forget. Not the last place in this, for example, in this list has such an interesting drug as the Gol. In fact, it refers to homeopathy and our traditional medicine. It is homeopathy that is treated with a high degree of caution. And if you remember, recently the Academy of Sciences has generally recognized homeopathy as a science, but no one says that it is ineffective. That is, the goal is to stimulate the formation of a spike, and this is what we need here in terms of sanogenesis, but this looseness of the vertebral motor segment, it is desirable that woven jumpers form as quickly as possible so that our excessive mobility is fixed with you. Puncture treatment, what we talked about when there was a slide about discography. This type of treatment of intervertebral disc lesion is intermediate between conservative therapy and open surgery. Puncture treatment is indicated for protrusion, that is, for protrusion of discs and for instability of the vertebral motor segment. After simple breaks, it is also possible to apply it in principle, but most often used after protrusions. Well, here schematically shows the moment of puncture of the cervical intervertebral discs with anterior access, yes, as well as the lumbar intervertebral disc with posterior transdual access or lateral access. That's what happens in reputational treatment. The so-called disc dissection is performed. That is, you can inject alcohol into the intervertebral disc with a cocaine mixture. This is the minimum evil from where we started. Yes, in order to destroy the end of the vertebral nerve sinus in the fibrous ring and, as a result, remove the pain component, remove the vicious circle associated with the response to this pain component. It will have a therapeutic effect. These resections, which are carried out during spinal traction, are most effective and functional. Another option is popoinization or so-called chemonucleasis, when an antilytic enzyme is injected into the disc. Well, we usually started with such an enzyme as papain. It is able to selectively dissolve parts of the nucleus pulposus, yes, related specifically to protein molecules. And a few months later, fibrous fusion of adjacent vertebrae occurs on the site of this case. Adhesive stabilization of the intervertebral disc, that is, insertion into the intervertebral disc during spinal traction. Well, they used to start with medical glue Mk9, now they use bone cements, yes, capable of quickly solidifying on the basis of methylcreatine, and fixing this is the most increased distance between the vertebrae. That is, in fact, it glues the vertebrae together. Not a frequent technique, but as a fact it should be described that it takes place. After a few weeks, the glue dissolves and fibrous fusion of adjacent vertebrae occurs again. A more serious thing is surgical treatment. The absolute indication for operations is the clinic of acute compression of the roots of the ponytail, that is, a dropped intervertebral disc. Procrastination with an emergency operation, with the focus on this very prolapse, can lead after some time to irreversible consequences, that is, to the formation of irreversible persistent disorders in the roots, yes, nerve conduction. Relative indications for surgery are a pronounced compression syndrome of the spinal cord roots or a persistent syndrome of instability of the vertebral motor segment when at least 3 to 4 months of conservative therapy does not give effect. And it is also a syndrome of compression of the cervical spinal cord. With partial or complete loss of the intervertebral disc, decompression of the spinal cord roots will change. Here is the posterior axis, the spinal canal. The following back access methods are used for decompression. Please note that you are required to carefully remember the name of these operational manuals. Yes, what are these operations and what is their essence? So, facetectomy. These facet joints can put pressure on nerve endings. As a result, their removal is required. Yes, the intervertebral joint is not the most necessary thing, as you remember. It is the intervertebral joint, which is represented by the joint between the vertebral bodies, that carries a large degree of load. Therefore, facetectomy is the removal of facet joints. Foraminotomy, that is, if a part of the disc or bone spur of the osteophyte infringes on the nerve exiting the vertebra through the root canal, then such an operation as a formotomy is prescribed. During this procedure, the size of the root canal increases. That is, such an increase leads to the release of nerves from crushing and their free passage of impulses through them. Laminotomy is more crippling, let's say, an operation. Yes, this is the removal of the posterior part of the vertebra, which serves to protect our spinal canal. Due to its proximity, it can put pressure on the spinal cord. Well, in this case, choosing a bow, we carry out with you, as it were, decompression of the spinal cord in the spinal canal. Yes? And laminotomy, yes, like formotomy, yes, with lamentomy, the whole inside simply increases, through which the spinal canal passes, but by a slight expiration. This is our DOSCI. Unlike viectomy, only a fragment of the doge can be removed and not to such an extent the consequences will already be life-threatening for the patient when a person is missing one of the soles. In case of instability of the vertebral motor segment, decompression and stabilizing operations are used during the protrusion of discs. That is, anterior access to the spine. Decompression in this case will be based on the removal of the disc, and stabilization is with you and me with PODIS, that is, ensuring immobility in the spinal motor signal. Well, what can we offer here? Discectomy, that is, with a protrusion or herniation of the intervertebral disc, which exerts pressure on the nerves, the entire disc is removed. Yes, the whole disc, along with those fragments that fall towards the spinal cord. Corpectomy. During this procedure, the entire body of the vertebra and the intervertebral disc adjacent to it are removed. A bone graft is inserted into the place of the removed vertebra. Yes, often an autograft and a fusion of 3 vertebral segments is performed, that is, spondiote is provided. Well, pay attention here. Here we see the cervical spine during surgery after anterior decompression of the spinal cord, when the disc was completely removed and the implant was stabilized. The implant connects 2 vertebrae and, of course, does not fully perform the function of a disc. Yes, that is, no elasticity and movement is no longer assumed here. Here is the rotation of these vertebrae between each other. Endoscopic method of removing the protrusion of the disc. Yes, that is, in this case, the endoscope is injected punctually directly into the cavity of the intervertebral disc, part of the spinal core is removed, or microtools are used to destroy their removal, yes, or subjected to thermal destruction using a laser, the so-called evaporation of the disc is performed. At this wedding, you are presented with a small video clip on the course of the operation. In this case, an endoscopic method under the control of an interoperable X-ray will mechanically remove a fragment of the disc, that is, a protrusion of the disc. Please watch this video to the end. No serious and lengthy comments are required here. The authors of the video will show you the course of the operation, that is, the moment of access, data control of all manipulations in a genealogical way. Then the tools that will be used to dive there directly into the area of the intervertebral disc and the very moment of extracting this fragment of the disc before will be shown. So watch until the end of the operation. Please note that the removal of a part of the intervertebral disc or an entire vertebra leads to destabilization of the spine. To avoid such complications, the vertebrae are rigidly fixed together. The operation is called spongiodessa. In most cases, the vertebral fusion method is used through the posterior or anterior access. That is, it is a rear or front spongiodessa. An environment is created in which the bones of the spine grow together within a few months. To replace voids, a bone autograft from their own bone is used. Sometimes donor bone is used, and most often recently various synthetic biological substances or cements, which we talked about in the lecture above, and also talked about at the last lecture. An alternative to spondiodeso, thanks to advances in prosthetics, it was possible to develop models of artificial intervertebral discs which avoids the fusion of vertebrae after a complete discectomy. In the operation, the damaged disc is removed, and an artificial one is placed in its place. Partial prosthetics. Another method of prosthetics of the intervertebral disc involves replacing not the entire disc, but only its pulpous nucleus. This method allows you to restore the height of the disc and normalize the movement of the spine. During the operation, instead of a complete discectomy, only the internal jelly-like material is removed, and a soft pad made of polymer material is placed in its place. With this, let me finish the lecture. Have a nice day. Goodbye.